Hello, my name is Vivian Haggerty, and my presentation today is titled Inpatient Hospital Outcomes and its Association with Insurance Type Among Pediatric Neurosurgery Trauma Patients. Over the history of the U.S. healthcare system, health insurance status has been a known contributor of inequities in health outcomes. Like many other outcomes, neurosurgery outcomes have been shown to vary by one's insurance status. Studies among adult patients undergoing neurosurgical intervention have established greater mortality rates and longer inpatient treatment for uninsured versus privately insured patients. This is also true of pediatric patients undergoing surgical treatment for epilepsy. However, to date, few studies have addressed the impact of insurance status on clinical outcomes for pediatric neurosurgery patients undergoing procedures following intracranial trauma. Despite the passage of the 1986 Emergency Medical Treatment and Active Labor Act, EMTALA, which was intended to prevent treatment delay or refusal for uninsured or underinsured patients, uninsured pediatric trauma patients continue to have a higher mortality. The goal of this study was to establish the extent to which insurance status, Medicaid, private insurance, self-pay, or other, correlates with inpatient mortality, length of stay, and favorable discharge disposition among pediatric neurosurgery patients undergoing treatment for intracranial trauma. We hypothesized that privately insured patients would be more likely to have favorable discharge dispositions, reduced hospital length of stay, and lower mortality rates compared with patients with Medicaid undergoing similar procedures. Records of pediatric neurosurgery patients from birth to 17 years old were extracted from the 2006, 2009, and 2012 Healthcare Cost and Utilization Project Kids and Patient Database, or the KID. Produced every 3 years, KID is the largest publicly available all-payer inpatient database of patients younger than 21 years old in the United States, with an unweighted sample size of approximately 3 million pediatric discharges and a weighted sample size of almost 7 million discharges. With the use of discharge weights, KID allows for national estimates. Our study population included pediatric neurosurgery patients 0 to 17 years old who underwent procedures following intracranial trauma. Codes were chosen based on the most common codes for surgery for trauma and hematoma according to the American Association of Neurological Surgeons Guide to Coding. Tables 1 and 2 present results of our study's primary analysis. After adjusting for socioeconomic factors, clinical factors, and hospital characteristics, we found that self-pay patients were 2.5 times more likely to die during hospitalization, which was statistically significant with a p-value of 0.008. In our assessment of the study's secondary outcome measures, results showed that pediatric neurosurgery trauma patients with private insurance had a reduced length of stay of approximately 1 day, with a p-value of 0.004, and had an increased likelihood of favorable discharge disposition, p-value of 0.034, when compared with Medicaid patients. Both results reached statistical significance. The current body of literature establishes insurance status as a potent predictor of outcomes, particularly mortality, in pediatric trauma patients. A 2012 study by Short used the National Trauma Data Bank to examine the relationship between pediatric trauma outcomes and insurance status, private, Medicaid, or no insurance, and found the variable to predict mortality independently of race. In a 2017 single-center study spanning 25 years, Reed documented a 2.8-fold increase in mortality rate for uninsured pediatric trauma patients compared to privately insured patients. In addition to access to care barriers faced by uninsured patients, research has shown that uninsured patients, along with their parents or caregivers, are more likely than insured patients to have a language barrier or lower rate of health literacy, potentially complicating crucial communication with healthcare professionals. Research has also shown a correlation between limited preventive care, delays in medical treatment, poorer clinical outcomes, and worse overall health of children of parents with limited English skills. Finally, in a single-center cohort study, uninsured patients who suffered traumatic brain injuries suffered worse long-term functional outcomes than their insured counterparts, possibly due to limited access to rehabilitation or home health care after inpatient treatment or lower socioeconomic status with fewer available resources more generally. As trauma patients are difficult to follow after hospital discharge, mortality and length of stay remain the preferred metrics to assess trauma outcomes. Given the potential long-term sequelae associated with traumatic brain insults, it is critical to precisely identify disparities in care to mitigate adverse outcomes and promote equitable, high-quality care for all patients without regard to insurance status. To our knowledge, no study to date has focused on assessing mortality and length of stay across the cohort of pediatric neurosurgical trauma patients. As the factors influencing mortality and length of stay vary based on patient population and mechanism of injury, accurate assessment of factors impacting traumatic brain injury care in pediatric patients is crucial. More research is needed to elucidate the factors underlying the 2.5-fold increased risk of inpatient death among self-pay trauma patients compared with Medicaid patients, especially as the law mandates equal treatment for all emergent patients under EMTALA. Given the convoluted nature of healthcare quality, an interplay of economic, social, and patient-specific factors must be considered as it relates to the results of our study. If you are interested in reading more details about our study, our paper is published in volume 141 of World Neurosurgery with the title as shown. Thank you for your attention.